Hello, everyone, and welcome to the RSA series of webinars delivered on behalf of the Royal College of Surgeons of Edinburgh. We'll be talking today about hand injuries, and I have the pleasure of having Mr. Dan Saleh. He's a consultant plastic surgeon at Newcastle. He has a special interest in microvascular surgery and surgical oncology. He'll be telling us all about hand injuries. It's been quite important topic, especially with the COVID and people staying at home and doing some DIY stuff. So there's lots of hand injuries around nowadays. It's also important to note that you can submit your questions through the Q&A tab on the chat. And we'll be trying to answer as many as possible as we go along, and we'll save several at the end. Dan, it's all yours.
Thanks, Eamon, and hello everybody, good afternoon. I hope this is a sort of crash course in how to approach the acutely injured hand and how to go about doing the right thing and making a reasonable assessment. I'll say slide at the end of each slide because somebody's cycling through the slides for me, so don't worry if that's off-putting. And on that note, slide please. So I think we're going to cover how to acutely manage these, how to make sure that you don't miss anything when you're assessing the patient, and then how to make sure that you support the patient's hand for their onward treatment, whether that be surgical or conservative. Slide. I think it's important when you're assessing a hand to consider the sort of the lingo, if you like, where the hand is concerned. So radial is the thumb side or the radial side in the anatomical position, which is palms facing upwards if you're lying down in bed. So radial is the thumb and index side, and ulnar is the little finger side. So that's important when we come to actually looking at which side of a digit is even injured. So if the thumb side of one of the digits is injured, we'd call that the radial side, and similarly for the ulnar. The palmar or volar aspect of the hand, or the flexor surface, plus the flexor creases, can be used to describe levels of injury. There's also what we call flexor levels of injury right from the wrist up into the digits, which I won't get into the detail of, but give you an idea of where that patient has injured their finger or their hand. And similarly on the dorsal or extensor surface, that's probably the better terminology rather than posterior, anterior, because that can get quite confusing where the hand and the wrist is concerned. Slide. So it's a very complex organ, the hand. It's very busy and there's lots of anatomy tightly packed in. The majority of the clockwork of the hand is on the volar or flexor surface, which is essentially paired flexor tendons, so deep and superficial ones, including the thumb, the hypothenar eminence and the thenar eminence, within which are very specific motor nerves that supply and allow that very fine motor movement of the thumb and the little finger. And we also have paired digital nerves and arteries, which come from the arterial cascade and the neural cascade between the terminal motor ends of the ulnar nerve, particularly within the palm of the hand, and they give off digital nerves and vessels on the ulnar and radial volar surfaces of every digit. On the dorsal surface, there's a little less going on. It's primarily extensor tendons. However, in some respects, extensor tendons are harder to treat and injuries harder to recognize, which I'll come to. There are dorsal nerves, particularly on the radial aspect of the hand in the dorsal snuff box and into the index finger and thumb. And there's an ulnar dorsal branch as well, which comes around the ulnar styloid on the posterior or extensor surface of the wrist to terminate in the digits as well. And the primary pathway of venous drainage of the hand is on the dorsum of the hand, which is obvious. When you look at your hand, you see the veins, but on the volar surface, there's very little venous tissue that is certainly large or contributes significantly to drainage. Slide. So the first thing is that invariably, if the patient's got an open wound, the priority is to stop the bleeding. And so the priority isn't to put a very tight circumferential dressing up, which will compromise the blood supply further. And if anything, when you take that bandage off, give you a reflex hemorrhage because the patient has had relative ischemia, so they get reperfusion and significant vasodilation and a harder problem to treat. And hemorrhage, the best way to stop any hemorrhage, and this will stop hemorrhage even in patients that are anticoagulated, is to identify the bleeding point, put some damp gauze in your thumb or your index finger and put point pressure on the hand and elevate that limb, and have the patient lying down if they need to or reclined, and put the patient in a Bradford sling or a high arm sling. That will stop the bleeding without tight dressings which will compromise the hand function acutely and long term. So that's the first step where you're faced with patients that have a wound in their hand. Slide. So then, slide again, when you're applying pressure or you've got something to apply pressure, you need to get some key bits of information which will very much guide your management. So first of all, what's their occupation and hand dominance? Many hand injuries, particularly in people that are manual workers and their trade involves them using their hands, their key driver is to get back to work. They're not interested in fancy reconstructive methods, and they will take the path of least resistance to get healed or have their bone knit and get out of your clinic and get on with work. So their occupation is a big driver and motivation about sometimes how you treat patients. How did they do it exactly and when? And the reason for knowing the exact mechanism is what contaminants may they have, what level of the injury may be. So sometimes when you have a clasped hand and you might be worried about a flexor tendon injury, when the hand is opened up or the palm is opened up, the level of the tendon injury doesn't correlate with where the wound is because the tendon would have been in a different position. And also timing is important because of fight bites. So wounds that you get on the hand, on the dorsum of the hand, people punching and they're catching teeth, they can be very, very toxic and highly infective. Or animal bites, and what environment did they injure themselves in? So, for an example, if somebody's cut their hand from an angle grinder, was it a fresh blade, or has that angle grinder been in some dirty metal? And the other key question, I think, is did they notice an immediate change in function? So particularly where paresthesia is concerned, most people get paresthesia if they've got a swollen digit, a swollen hand, or a swollen limb. They will get some altered sensibility and it will feel different by virtue of the swelling. But if they suddenly notice that they had profound pins and needles or a change in sensation from the word go, that may be very, very important. It's also worth asking them, did they see spurting blood, if the blood has stopped, and what kind of pattern of bleeding did they have? And then it's, if possible, get the patient out of pain or do things that can help the patient's pain, whether that's temporarily splinting the hand, giving them some oral analgesics, or if it's a child, giving them some intranasal analgesic, or indeed numbing or ring blocking the digits so you can make a proper assessment and get the appropriate treatment plan together. Next slide. So firstly, observation with a hand injury, whether it's closed or there's an obvious wound, you can get a huge amount from just looking at what's going on. So that's a normal cascade of a hand. So when you put the hand in resting position, or you put your elbow on the table with your hand sticking up and let your wrist flop forward, you'll see a normal cascade. And most of the digits generally point towards the scaphoid region or the thenar region of the hand. So the index and middle finger look straighter, whereas the little finger and ring finger tend to curl and angle slightly obliquely, pointing towards the thenar area. You can get some obvious deformities in the cascade with closed injuries, whereby the metacarpals are broken, for example, or they have a wrist fracture, and that alters the dynamics of the digits and they point in different directions, so they can be rotated or scissoring. So that can allude to closed significant injury. And if they have wounds, you may have a totally different appearance of the cascade entirely. So slide, please. So for example, if you had a volar wound on that little finger there and the finger isn't following the rest of the cascade, then that would immediately alert you to, well, is there a problem with the flexor tendons? Most of the flexors and the way we get a cascade like that is because of the tenodesis effect. So the volar or the flexor muscle bulk are largely shared amongst the tendons. And so as you'll know, moving a couple of the digits often incurs moving the other digits. So if we go to the next slide. So when we move the wrist in certain positions, you get a mass effect. So if that mass effect can't be recreated and the cascade doesn't look normal when you either move the hand in this way, or you can even just gently put pressure on the proximal forearm to curl the fingers up, then it's likely that there might be a closed or open tendon injury if they have a wound. Next slide. So key points for examination. Slide. We mentioned deformity. Where's the wound and what caused it? So fragments of glass or glass wounds, they tend to be very penetrative. The glass will cut as far as it can go, whereas often with a blade cut, unless someone's being attacked, we'll reflex pull our finger away from a blade if it's a self-inflicted knife wound, you know, preparing food or cutting carpets or whatever. If they have a blunt injury with a wound, then you have to have significant concern of crush and whether there's going to be significant reflex swelling in that part of the hand or digit. And if they were injured by a machine, have they got a combination of a crush and sharp injury or a crush and avulsion injury? And sometimes you can get closed avulsions of blood vessels and nerves, so they can have the symptoms of a division of a nerve with no visible external wound. The primary thing to ascertain is the vascular status of a digit. In the vast majority of cases, a very simple, not pinprick, but just gentle digital pressure on the pulp of the digit will give you a good capillary refill and give you good vascular status. Similarly, the tendons, you can check their cascade, and we'll come to checking individual tendons. And then I move on to examining the nerves. And then you can assess for bony tenderness with or without the luxury of an X-ray. And if they have a significant wound, then you can see, well, have they lost any skin? Has skin been taken out in this wound, and how am I going to replace that skin? Or if there isn't skin loss, is the skin degloved? Does it look like it has a good blood supply, or is it mottled and looking very unhappy? Slide. So a very quick screening examination, like if you're in A&E, for example, is the cascade normal? Is there an obvious deformity that I can see which fits with the mechanism of injury? Can they move their hand? Can they make a fist and straighten their fingers? If they can, they're already doing pretty well. And never forget the wrist. Always check whether they can use the wrist adequately, because wounds, even in the proximal palmar region of the hand, can incur significant wrist flexor injury and they can't flex their wrists properly. Slide. So the vascular status. So the primary arterial inflow to the digits is on these paired volar digital arteries. And it's the same for the thumb. The thumb and the index finger have the luxury of the posterior branch as well, coming from the superficial radial branch of the artery. But otherwise, it's primarily volar, and there are dominant vessels from one side of the hand to the other. So, for example, the ulnar digital artery on the ulnar side of the little finger is tiny compared to its radial counterpart, which kind of makes sense because that's the bit that's exposed, and we've probably evolved to have a smaller blood vessel there because of defense injury and so on. And it's the same with regard to the index finger. So the radial side of the index finger has a relatively small artery versus the ulnar side. For the central two digits and the thumb, there isn't significant radial or ulnar dominance. So basically, in the vast majority of cases, one of those arteries can be divided and you would not clinically see a difference in vascular status. But in patients that have a volar injury across the whole width of the digit, may be at risk of a complete vascular injury. And it's really important you do a very good capillary refill test of the pulp. Does the pulp look as full as the other pulp? So does it look perfused? Does it feel boggy, or does it feel nice and full? And sometimes you can have an isolated arterial injury, and you can still have dorsal inflow through a small dorsal artery by chance, but they have very poor venous drainage on the back of the digit, and so they get a congested digit, which is important to recognize as well. Slide. Sometimes other things can mess with the vascular status of a digit. So has the patient had a ring block? Occasionally in A&E, very reasonably, the A&E doctors will do a ring block for analgesia and to assess the thumb or the digit, with a washout. So sometimes the ring block can not only injure the vessel itself by the needle, but can also compress the vessels around that area and blanch the digit. So it's worth getting an idea of when they were ring blocked and with what. And occasionally people use adrenaline, which again is not unreasonable. We're always told not to do that, but it's not unreasonable. So they may well have a good reason for a white finger aside from their injury. Have they got a tourniquet on? Sometimes patients that have major wrist injuries and they've had a frightening spurting radial artery or ulnar artery injury, going back to the very beginning, those injuries might be frightening and you get a profuse bleed, but point pressure with something that won't stick to the wound, so some damp gauze or some Vaseline impregnated gauze, that will stop, and you can put a light bandage on and elevate them, and they won't have any further bleeding. But if they do have a tourniquet on, they will get a reflex hyperemia. They may get a significant bleed when you take the tourniquet down, and they may present to you with the tourniquet on, so you need to get a good idea of what's going on. And then sometimes you get a patient who has a thumb or the digits that look very purple, and it's because the arterial inflow is working away fine, but the venous outflow has been occluded because it has a lower vascular pressure and the dressing's too tight. The other common thing we see, and you must be wary of, is that if the patient has a circumferential dressing on a wound and they've bled into that wound, the blood hardens the dressing if it's not non-stick. So if it's dry gauze, it will harden the dressing, and by virtue of it being circumferential, will create a tourniquet. So never be afraid to take a dressing down, no matter how much somebody tells you it's bled or it's been unpleasant or it took them an hour to stop it bleeding. You need to examine the whole hand and the vascular status. Slide. So tendons. The easiest way to examine the tendons is to break down, concentrate on the 4 digits first. At the DIPJ, or the distal flexion crease, you can examine the FDP. So you mobilize the whole digit up to that joint and ask them to curl their finger forward. Then similarly, because of the mass movement of the FDS tendon, or the superficial flexors, you need to immobilize the other 3 digits and then place your finger over the metacarpophalangeal crease and ask them to bend their finger up to assess for the isolated FDS. So by keeping the other finger straight, the FDP can't contribute to the flexion. And you need to do that for every single digit to assess whether they have a closed injury or an injury that correlates with a cut on the finger or the palm. The thumb has just 1 flexor and 1 flexion crease at the IPJ. And as you can see in the diagram on the left, just immobilize the joint into extension at the metacarpophalangeal joint and then ask them to bend down. And with resistance, try push it back. If patients have pain, when you give them a bit of resistance to try straighten the finger, they may have a partial tendon injury, and that warrants an exploration, because if they go home in a couple of weeks, by the time they've used their thumb or their digit, it's like a frayed rope, it will just snap, and then you have quite a challenging problem on your hand. Next slide. Similarly, for the extensors, you can glean some information from the observation. A very common extensor injury is a cricket ball or a bat or some kind of what we call axial injury, so hitting an extended finger head on. So you can see in the lower left diagram there that the patient has the flexor tendon takes over the position of the joint because it has no equalizing extensor working, and so you get what's called a mallet deformity. And you can get extensor lag in any digit when you ask them to hover their hand up and keep it flat. So if a finger lags, then it's probably got a partial or complete extensor injury. When you get proximal to the knuckles on the back of the hand at the MCPJs, extensor tendons have a capacity to retract more in the wound like a flexor tendon. If you're distal to that, the juncturae in the extensors prevent significant retraction, so you can often explore the wound under local anesthetic and get an idea of whether the tendon's cut or not, because it's subcutaneous basically, unlike the flexors. And then EPL, so the extensor pollicis longus, if you just put the hand flat on the table and then ask the patient to lift their thumb up to the sky, you'll see the tendon become active and you can palpate it in the snuff box. Slide. And you can see there the juncturae just proximal to where the MCPJs are, and that's where you get minimal retraction, but then in the dorsal wrist area you can get significant retraction of the extensors. Slide. I think the hand examination neurologically can be very, very detailed, and quite often it needs to be, particularly in the chronic or in patients that are referred electively. But in acute injuries, largely speaking, if they have an obvious motor nerve injury, you're going to be exploring that nerve, and you may find other nerve injuries that aren't immediately apparent on your screening examination. But generally, I ask the patient to do these 3 things. Do an OK sign, an A-OK, thumbs up, and cross your fingers. That will basically tell you if they can do all of those things, even with discomfort, they're likely to have median nerve innervation, radial nerve innervation, and ulnar nerve innervation. You can ask the patients to spread their fingers and resist you pushing the index and little finger together. And you can ask the patients also to get their thumb to go to their little finger and to not allow you to break the circle that they create doing that. That's an additional test to test the recurrent motor nerve of the median nerve for palmar lacerations. But generally, that screening sort of mechanism will give you a very clear idea of if the patient has a major motor nerve injury. Slide. The paired digital nerves on the volar surfaces, particularly the thumb and the 4 digits, the terminal branches of the ulnar nerve and the ulnar tunnel, and also the median nerve give rise to these nerves, and you have one on each side of the digit. So it's quite handy if you have a laceration to the side of a digit and they're saying they have to soft touch pins and needles from one side when it feels completely different to the other side. That'll give you an idea of whether they've got a digital nerve injury. And that's quite common. They're the commonest nerve injuries we see in reconstructive surgery. You can, slide please. You can do the tactile adherence test. So if you're not entirely sure if they've definitely got a nerve injury, they lose the inability to sweat. So the digit becomes very smooth rather than having a bit of sweat that can grip things. So if you get a pen or just a standard pen from your pocket and run it down the affected side of the finger and it runs down smoothly, whereas on a normal digit or on the other hand, it sort of gets stuck a little bit, then that's called the tactile adherence test, and it's very sensitive to having a nerve injury. And if they think they've had pins and needles from the word go, from when they injured their finger, it's likely they have a nerve injury. In patients that have clear arterial insufficiency to a digit, and that's coupled with a volar wound, then the arteries sit slightly anterior in the digit or slightly volar to the nerves. The nerves sit slightly volar to the arteries. So if you have a significant arterial injury and you have a devascularized digit, it's likely they have they don't have their nerves in continuity either. So that's another sign that you might need to repair nerves. Slide. And these are some other danger zones that, if you like, exposed areas of the hand and the wrist, particularly the superficial radial nerve that comes dorsally under the brachioradialis into the dorsum of the hand. It's subcutaneous, and sometimes if you tap quite hard on your wrist in those areas, you can give yourself a jolt, and it's always at risk of sharp injury in that area, particularly for people that have manual work. And so if you have a wound in that area and they have any form of numbness over the middle finger, index or thumb, then really you should be exploring that wound unless there's a reason not to. Next slide. The bones. So closed injuries of the hand are most commonly fractures and most commonly metacarpal fractures from interpersonal violence or dropping things on the hands and getting blunt injuries. So you can ask patients to make a fist or have a look at their cascade by gently compressing their forearm, because if you tighten the forearm, it'll bring the flexors in. Scissoring is where you have one digit slide under the other digit very noticeably. You'll notice in your own hand that in most people, the little finger tries to slide slightly under the ring finger when you make a gentle fist. But if it's very profound, that scissoring can mean that the broken metacarpal head particularly is rotated, and that's something that needs sorting out. So really one of the key things you want to look at as well is get the patient to hold out their hands and straighten their digits for you and look down the digits as if you're looking down axially and see if they look rotated or they don't look in line with the other digits. That can allude to a significant bony and ligamentous disruption as well. Obviously, if the patient's complaining of tenderness and they have point tenderness, it's possible they have a bony injury, and that should prompt an X-ray examination. Slide. So overall, X-rays, don't just get an AP and a lateral, try getting an oblique as well, because in complex fracture patterns, you may have spiral and oblique fractures, which need certainly a different type of surgical management, perhaps. If you feel the need to assess the digit and you can't really assess the wound, it's too sore for the patients, ring blocks are very, very helpful. I generally use plain lignocaine or plain chirocaine because it's longer lasting. and you only need 5 to 7 mils, and you can do it all dorsally. The sensory innervation to the dorsum of the digit is less dense than the volar surface, so it's less painful basically. So use the finest gauge needle you can in a Luolock 5 mil or 10 mil syringe, and just past the MCPJ or the web space creases, angle slightly obliquely and put a little bit of local in where your skin is, and then wait for that to work for 30 seconds, and then advance your needle, put another little bit in. So you're always advancing the needle through a bit that's already numb until you can see you're tenting the volar skin, and then you can put a bolus of a couple of mils in there, and that'll give you a numb finger within 10 minutes. And then you can assess them. They won't feel painful when they try to move their hand, and you can assess the wound if it's appropriate to do so. Always put a non-stick dressing on. So either a saline soaked piece of gauze, a piece of Gelinet, or a piece of Mepitel, which are all readily available in most dressings trolleys. That will save the patient the headache and the heartache of having something sticky pulled off a raw wound, which is painful. And do not make dressings circumferential. If you put a dressing, even a non-stick one, circumferentially around the digit, and the digit swells and the dressing is too snug, they will get a tourniquet effect, and you can threaten that digit. Splintage is very useful for soft tissue injuries and bony injuries, because splintage removes pain as well. And the Edinburgh position is the standard sort of position for bony injuries of the digits, and also for extensor tendon injuries for the digits. And that involves some hyperextension of the wrist and flexion of the MCPJs in about 35, 45 degrees. And the easiest way to do that is to get the patient to put the actual plaster roll in the small of their wrist with their hand facing up to the ceiling. And then when you've got that in the small of the wrist, you can get a flat hand to the floor and put a volar slab on, and that's very straightforward. Dorsal slabs are very useful for flexor tendon injuries. So if you imagine, if you're worried that there might be a partial flexor injury or a complete flexor injury, if you extend the wrist, that will widen the gap between the tendon endings. But if you flex the wrist, it brings them closer together. So putting a dorsal slab on the wrist until the patient has a definitive assessment or a procedure can reduce the distance and the gap and the hematoma between the tendon ends. So that's very useful. And Zimmer splints are just simple splints to mobilize digits, and they're malleable, and they have a soft padding on, and they're readily available in most places. And I think really that's my crash course to assessing a hand and getting to grips with an acute hand, and should get you out of most situations with a coherent plan to anybody that you're onwardly referring, or to within your team if you're part of the junior surgeons of the plastics or the orthopedic team. Okay, I think that's all I've got to say. Great
talk, Dan. There's a couple of questions actually the audience have put forward. One is about if you've got a transected digit, for example, out in the field, and you're transporting that to the hospital, what's the best way of doing that? How do you transport that digit or organ, let's say?
Yeah, so the whole principle of any removed part of a body is try reduce the warm ischemic time, which means cooling the part. So wrapping the digit or the part in saline soaked gauze, and that keeps it neutral. So water's a bad thing because it will damage cellular activity when you potentially reperfuse that part or digit. And then placing that in a small Ziploc bag, and then putting that within another Ziploc bag that has a bed of ice in it, will cool the digits and give you a better chance of potential replantation if that's what you aspire to do. And normally the limit of replantation, certainly for a digit, because it's metabolically not mega high demand, I would say probably be about somewhere between 18 and 24 hours. So depending on the circumstance, if the rest of the patient's okay, then you should do that, deliver the digit, and then the team receiving the digit should probably take the digit off and dissect it while they're waiting for the patient to go to sleep to put it back on if it's appropriate.
Thanks for that, Dan. The other question is, you mentioned that you wouldn't apply a circumferential dressing to a digit. So how would you do that? How do you mean that you're going to apply different dressings? If you've got a wound, let's say, all around the digit, how are you going to dress that wound?
Yeah, so if you've got a circumferential wound, or you've got a wound in two parts, then I just sandwich the digit. So they have a bit of gauze posteriorly or on the extensor surface, and a square of gauze on the volar surface. So that will try avoid the potential tourniquet effect you may get on that digit. And provided that on that gauze is a non-stick interface, then that will support the wound adequately until they have a definitive treatment. There are more elaborate ways that you can dress a digit. So if you have a square piece of gauze, if you take out two small squares out of one, two corners, it'll give you I don't know what, it's like almost like a keystone with a project, like a peg. And you put, if you like, the hat of that bit of dressing over the tip of the digit, and the rest of it wraps around without going circumferential. That sometimes people improvise and do quite fancy things like that. It's not unreasonable to house the dressing in a digital dressing that is like a piece of net that does go around the whole dressing, but the actual dressing and the interface with the wound underneath that is ideally shouldn't be circumferential.
Thanks for that. I've got a question, if you don't mind, Dan. And that's to do about fight bites.
Oh yeah.
So there's a lot of controversy about these. People say you've got to take them to the theatre and wash them, explore them, extend the wound, wash them. Others would say if you washed it properly in A&E and you've given them antibiotic, that will suffice. I don't know what your view about this is. A very common injury that we see.
It's a very common injury, and if I box animal bites with that as well, I don't know which school of thought you're from, but my personal view is if the patient presents at a reasonable juncture after the incident and they're not actively suppurating or pussing out, and they don't seem to have a tendon injury, then I ask them to sit by the sink in A&E or in the trauma clinic and put some tepid water on that isn't too hot for them and make them sit there for half an hour. Then I swirl the hand and the wound in a chlorhexidine or betadine bath. And then I give them oral antibiotics and send them on their way and see them in 24 or 48 hours to ensure that the wound isn't more infected. I think we by far over-operate on these patients, is my view.
I agree with you entirely on this. I'm of a similar view. I think if they present early and you're able to wash it adequately, then I think that's reasonable, provided that you cover them with antibiotics. And as you said, you follow them soon enough to notice if there's anything developing there.
Yeah, exactly that. Absolutely.
Yeah. The other thing that you mentioned is about giving local anesthetic with adrenaline. So again, I've worked with surgeons in my training who'd said never ever. Others would do it all the time. And I don't know what your views on these, because I mean our colleagues in A&E are the ones who are going to deliver these local anesthetic and digital blocks and all. They probably want some sound advice, let's say.
Yeah, I think the evidence is that it's entirely safe to use adrenaline. However, where there's dogma, there is a litigious angle, in my opinion. You only need a well-seasoned medico-legal expert who's 80 years old and been retired for 15 years, who's never heard of the concept of adrenalized digital block, to give you a headache and some sleepless nights. So certainly I don't use adrenaline at all in the digits. And more often than not, you don't need to. You don't need to hemostase to do what you're going to do as a digital block. And you can use digital tourniquets very effectively. So I don't see the need to invite the potential trouble. But I don't think it's criticism worthy if you do it. But I don't, because I just don't see that it adds a huge amount, but might add headache if you had a problem for whatever reason.
Thank you for that, Dan. I think this brings us to a closure really there. I would like to invite you all to the next webinar on Thursday. This will be on the principles of resuscitation and damage control and abdominal trauma. So look forward to having you all back on Thursday.